Hi, my name is Clinical Planners and you're watching the video Duane's Retraction Syndrome Classification. In this video, we'll discuss the various types of Duane syndrome and how we go about classifying the patient. You will recall that in previous videos, I've talked about how we'll be looking at the horizontal limitations, so the limitation of the abduction and adduction, to determine the type of Duane syndrome the patient has. In addition to this, I'm going to also bring your attention towards the end of the video to a variant of Duane's retraction syndrome known as Synergistic Divergence. Okay, let's get started. There are three types of Duane's retraction syndrome and we'll move methodically through each of these, commencing with type 1. So type 1 is actually the most common of all the DRS or Duane's retraction syndrome. And in this patient, we see limitation of abduction. And it could either be complete, so a -4, or it could be partial, in which case you might see -2 or 3. So if we have a look at the patient here to the right, what we can see is they have a left type 1 Duane's retraction syndrome. And when they look over here, we can see that the left eye is not abducting. And she's getting past midline, so it's not complete. It's probably about a -3 there. However, on adduction, they generally have normal adduction. It could be slightly limited or it could be completely normal. So if we have a look here, we can see that adduction looks okay for the left eye. But what we do see is a narrowing of the palpable fissures, and if we're able to take a closer look at her, we could see also retraction of the globe. She has no upshoots or downshoots, however you could see upshoots or downshoots on adduction in these patients. The other thing you may see is widening of the palpable fissures on abduction. So if we come back to abduction, here she is in primary position, here she is in abduction, and possibly there's a slight increase there on of the palpable fissures. Okay, that's type 1. So type 1 is characterised by the primary limitation being that of abduction, with adduction being relatively normal, or you could see a slight underaction of that medial rectus. The other features that you'll see is on adduction, those classic signs we talked about in the earlier video on the clinical characteristics. Globe retraction, narrowing of palpable fissures, plus or minus any up or down shoots. This is a Hess chart of a patient with a left type 1 Duane's retraction syndrome, and we can see here this patient has significant underaction of the lateral rectus. The eye actually doesn't even move past midline. And then we have the medial rectus being fine with no underaction of the medial rectus noted. Okay, now in type 2, abduction is fine or only slightly limited, and the primary limitation is that of adduction. So if we have a look at the patient here, as they move over into right gaze, and this patient has a left type 2 Duane's retraction syndrome, we can see significant underaction of the medial rectus. However, when he comes over into left gaze, abduction of the left eye is fine. So this instance is a type 2, and what distinguishes it from a isolated medial rectus palsy is here we have the narrowing of the palpable fissures. And again, if we could have a look to the side, we could actually see this globe retraction. This patient doesn't really have any significant upshoots or downshoots. It may be that eye in adduction is upshooting just slightly. But again, only 30% of your patients will actually show up or down shoots in adduction. But they should generally show or demonstrate narrowing of the palpable fissures and globe retraction. Let's have a look at a Hess chart of a patient with a type 2. In this example, we have a right type 2 Duane's retraction syndrome, and we can see that the medial rectus is limited, but there's no limitation of the lateral rectus. Type 3 Duane's retraction syndrome. Here we now have a limitation of both adduction and abduction. And if we have a look at the patient here to the right, this is a patient with a right type 3 Duane's retraction syndrome. When they're looking over to the right, we see quite significant limitation of the lateral rectus. And when they're looking over to the left, we see significant medial rectus underaction. We also see the narrowing of the palpable fissures and the widening of the palpable fissure here, and also some globe retraction over here as well, but no significant upshoots or downshoots. And here we have a Hess chart of a patient with a type 3 Duane's retraction syndrome, and here we see that there is limitation of the lateral rectus and limitation of the medial rectus. For this patient, the limitation is slightly asymmetrical. The limitation of the lateral rectus is more so than the limitation of the medial rectus. Now I want to bring your attention back to the bilateral Duane's retraction syndrome. In one of the earlier videos, I mentioned that you can have either a unilateral or bilateral DRS, and the bilaterals are about 20% of the population of individuals with Duane's retraction syndrome. Now, when you see a patient with a bilateral Duane's, you can subclassify the condition as type 1 or type 2, 3 for the right eye and the left eye. Let's take a look at the example here of a patient with a bilateral Duane's. They have both a right and a left Duane's retraction syndrome. Let's start off with observing just the left eye. As the patient moves into right gaze, the left eye has limited adduction. And as the patient moves into left gaze, abduction of the left eye is normal. In this instance, we would classify the left eye's Duane's retraction syndrome as a type 2 because adduction is affected and abduction is not. Let's move on to the right eye now. If we move into right gaze, we can see limited abduction. If we move into left gaze, the right eye now has a downshoot, and it's very difficult to see whether adduction is intact here or not. So this could either be a type 1 or a type 3, dependent on that adduction and whether it's limited or not. In this particular paper, it's indicated that it's a type 1, in which instance the clinicians have found that adduction is normal. It's just that the eye is downshooting in adduction in that particular instance. So here we have a bilateral Duane's retraction syndrome where the right eye is type 1 and the left eye is type 2. So don't be surprised when the right eye and the left eye in your bilaterals actually have different types of Duane's syndrome. This can happen. Okay, and finally I mentioned at the beginning that I'd just bring your attention to a variant of Duane's retraction syndrome known as synergistic divergence. This is actually extremely rare, but worth knowing about because you may come across it if you work in a strabismus clinic. And here again we have the miswiring of the third nerve where the nerve going to the medial rectus is also supplying the lateral rectus. But the difference now is that as the patient attempts to adduct, the eye abducts instead. Let's take a look at an example here of a patient to the right with synergistic divergence. In prime position, there seems to be an exotropia. When the patient moves over into right gaze, the right eye seems to have slightly limited abduction and the medial rectus of the left eye seems fine. Then as the patient moves over into left gaze, the left eye is coming across, normally abducting, but the right eye diverges out rather than coming across. And you can see it's diverged out as compared to the primary position here. Yes, it's exotropic, but it's actually gone in the opposite direction. It's gone into abduction rather than adducting. Now, why does the eye abduct on attempted adduction? In this particular instance, the lateral rectus is receiving either no innervation from the sixth or very little innervation from the sixth. But on top of this, the miswiring that's occurred where the medial rectus fibres are going both to the medial rectus and the lateral rectus, well, what's happening in this instance is that the majority are going to the actual lateral rectus. So the medial rectus is having very little innervation. It's mostly the lateral rectus. So as the patient attempts to adduct, the medial rectus is firing very little as compared to the lateral rectus, and therefore the eye will just diverge out. It's probably worth noting that some textbooks talk about this as a fourth type of Duane's retraction syndrome, but I rather consider it as a separate condition as synergistic divergence, and other textbooks will also talk about it as quite a separate condition but related or a variant of Duane's retraction syndrome. The types of Duane's retraction syndrome should be related to type 1, type 2, type 3, and the amount of limitation of AB and adduction. Synergistic divergence is similar to Duane's retraction syndrome, but is another condition. Okay, so in conclusion, there are three types of Duane's retraction syndrome, type 1, 2 and 3. These are determined by the amount of limitation of the AB and adduction that you notice. So with type 1, primarily abduction is affected, adduction is normal or only slightly limited. In type 2, primarily adduction is limited, with abduction being normal or only slightly limited. And in type 3, both are limited. It could be equally limited or asymmetrically limited, where one is a little bit more than the other. And finally, be aware of the condition synergistic divergence, which is rare but a variant of Duane's retraction syndrome, where the miswiring causes the eye to abduct on attempted adduction. Okay, that brings us to the conclusion of this video. Thank you for watching.